I'm Kate Brain. I'm a professor of health psychology based in Cardiff University School of Medicine's Division of Population Medicine. And my research interests are around behavioural aspects of cancer screening, prevention and early diagnosis, so quite broad, but particularly with a focus on inequalities. So yeah, thank you for inviting me today. I'm going to be talking about the value of including diverse voices in cancer early detection studies. And I'm going to be sharing insights from a behavioural science perspective, so slightly different from what we've heard, but really to try and demonstrate the difference that this can make to our different approaches to early detection. So first of all, I'm going to start with a few background slides just to set the scene for us. Bear with me. There we go. So you can see here, hopefully, there are two main routes to early detection of cancer. So firstly, screening the asymptomatic population. And through this approach, around about 5% of cancers are diagnosed through the UK National Screening Programme. So cervical, breast and bowel screening, and the recent recommendation by the UK National Screening Committee for lung screening, which is happening in England, and we had a pilot in Wales to target lung screening for adults with tobacco smoking histories. And I'll say a little bit more about that later. And the second route to cancer detection is through diagnosing symptoms in primary care for referrals for further tests and investigations. And actually, most cases of cancer are diagnosed in this setting. But unfortunately, both of these routes are really hampered by persistent inequalities that contribute to worse cancer outcomes in disadvantaged populations. So really, unfortunately, all things are not equal in cancer early detection, and there are persistent inequalities in screening uptake and stage diagnosis, with people from underserved populations disproportionately affected, unfortunately. And these inequalities exist not only by socioeconomic deprivation, which I've highlighted in red for reasons I'll come back to, but also among people from ethnic minority communities, people with physical and mental health comorbidities, people with intellectual disabilities, so a whole range of protected characteristics, and the intersection between these factors being less likely to participate in screening. But data on these other factors, other than deprivation, are actually quite sparse. So very briefly, these are the latest uptake figures for cancer screening programmes in Wales, shown by area level deprivation. And I'm not going to say too much about this because I think one of the later speakers is going to drill down into this a bit more. But just to show you that the deprivations gap is really stark, with differences in uptake between the most and least deprived communities in Wales across the screening programmes. But we can also see gaps in access to data on cancer screening. Screening uptake is typically presented by area level socioeconomic deprivation, but that's because these data are readily available, whereas data on other characteristics around, for example, ethnicity, are often incomplete. And this graph shows some data from the Scottish Bowel Screening Programme, where they linked census data, which has very complete data on ethnicity, with cancer screening data. And you can see here that there are significantly lower uptake in Indian, Pakistani, Bangladeshi and other South Asian communities, which is clearly unacceptable. But it really highlights the importance of addressing these gaps in routine data so that we can understand where the source of inequalities lie. And I just want to give a brief nod to lung screening, which, as I mentioned, has been recommended for national rollouts. It's very, very early days, but because lung screening is going to be targeted on adults with histories of tobacco smoking, then it carries a particular risk of non-participation because of issues to do with stigma around smoking. And also there are issues, I won't say too much about this, but there are also gaps in the completeness of primary care electronic health records on smoking. So you can see that there's potential for inequalities even at the stage where people are identified in primary care as being eligible for lung cancer screening. And these are some trial data from the Summit trial in England, which was led by Sammy Quaife and her team, and really just again show you this social gradient in uptake with people from more deprived quintiles and those who currently smoke being less likely to respond to the lung screening invitation. And there's unfortunately emerging evidence of further inequalities in lung screening participation by ethnicity. So these are the sorts of issues that we're going to have to address as the National Lung Screening Programme rolls out. So that was to set the scene. So in this talk, I want to really think about how we can tip the balance towards including the voices of underrepresented populations in cancer early detection research. And I just want to show you this image from that was borrowed from the Talking Trials community partnership that's led by Cardiff Trials Unit. Partly because I really like it. I think it's a really lovely image, but I think also it encapsulates the injustice inherent in not taking an inclusive approach. So that's really what I want to focus on. So I'm going to briefly describe a behavioural science framework that can be applied to understanding the barriers to cancer early detection. I'm going to give you 2 examples of co-designed approaches where we used behavioural science principles to address these barriers in the context of socioeconomic deprivation. And I'll finish up with some key recommendations. So some of you may know this framework, but it's essentially the combi model of the behaviour change wheel. And I've shown you this because it's a really useful practical framework for understanding the barriers to behaviour and then identifying practical solutions to overcoming those barriers. And I've used this a lot in my research because it's just a really, really useful approach. But basically describes how changing behaviour is a result of changing 3 conditions, so capability, opportunity and motivation. So for example, in the cancer early detection setting, you can imagine that, if you're not aware about the availability of cancer screening or studies around screening, then that reflects low capability or low knowledge. Sorry, I think I skipped ahead. Sorry, I'll go back. You can see that lack of physical access to services or study sites are structural barriers that reflect opportunity. And motivation, shown in the middle, is influenced by individuals' beliefs about the benefits or otherwise of early detection, often issues around stigma and fatalism, particularly in deprived communities that don't have the kind of resources available to them to be able to prioritise their health. So I just wanted to show you that framework and then demonstrate how we've used it in a couple of studies. So this is my first example of where we use the combi model in the context of the Abacus trial of a behavioural intervention that was designed to address some of those barriers that I've just described. So the Abacus Health Check was designed to increase awareness of cancer symptoms and to encourage early help seeking among adults living in deprived areas of the UK. So very briefly, it was an interactive touchscreen questionnaire which included questions about cancer symptoms, screening and risk factors that was delivered and facilitated by a trained lay advisor who went out to local communities to build rapport with participants and encourage behaviour change. So it was really about enablement through community outreach. And the point I want to make here is that we were able to demonstrate in a full phase 3 trial that the intervention was effective in improving awareness of symptoms in this population and encouraging help seeking at low cost. And then what I want to say here is thinking about working backwards. What was it about our approach that we think made sure that this intervention was effective? Well, importantly, we made sure that the patient and public voice was integrated from the very beginning. So we had a very extensive process of co-design with different stakeholders over a 3-year period, actually before the trial even started. And we had very strong PPI partnership at all stages of the study. And we partnered with Tenovus, who I'm sure you all know very well, because they had very strong grassroots connections with local communities. So we used those connections to do our phase 1 focus groups where we tested the intervention for acceptability in local community settings. And then we also carried out observational work in phase 2 to see how the intervention was being used in practice. So this was a really iterative process, which meant that we could troubleshoot any sort of issues before the trial started. And given the title of my talk, which is about involving voices, so these are some direct quotes from participants in this early developmental work. about the intervention and its delivery. So you can see here they talked about the intervention being convenient. It was easy to access. They found the lay advisor to be approachable and a good listener. And this translated into increased awareness of symptoms that would prompt a visit to the doctor. So hopefully what I'm showing you is that by involving the voices of people from our intended population from the very beginning, it means that our approach or our intervention is more likely to be acceptable and feasible, and therefore more likely to be effective. So just to say a little bit more about the trial, so flexibility was really key. So we had study materials that were developed for low literacy to increase capabilities, so going back to the combi model that I'd explained earlier. To promote opportunity of access, we use proactive recruitment methods in partnership with local community organisations. We had a very adaptable approach to intervention delivery, and we involved trained and trusted facilitators or lay advisors who were able to increase motivation in participants, but also in the community organisations that we were working with, who were the gatekeepers to our study population. So this flexibility translated into trial uptake of 52% in community settings and very, very high retention rates at 2 weeks and 6 months follow-up. And we think that this flexibility in our approach was the key. So if I have time, I just want to show you my second example before I finish up with some recommendations. So my second example is a bit different. It's the Yorkshire Enhanced Stop Smoking Trial, which is led by Professor Rachel Murray and Matt Callister. Essentially, it's testing an enhanced smoking cessation intervention embedded within the Yorkshire Lung Screening Trial for people at high risk of lung cancer based on age and smoking history. So community-based lung screening was delivered, you can see from the picture here, was delivered in deprived areas on mobile units in places like supermarket car parks to increase opportunity. And participants were offered an immediate consultation with a trained stop smoking practitioner on the van, so in a sense a captive audience, and they were offered ongoing support over the subsequent weeks. So the intervention, which we had co-designed in a series of developmental studies, which I won't go into in depth here, but essentially just to say the intervention was a personalised booklet which used images of the person's own scan results showing their heart and lungs to show areas of damage. The stop smoking practitioner was trained to deliver that information and to communicate risk information, essentially using behaviour change techniques designed to encourage a quit attempt to increase people's motivation to stop smoking. So we led the process evaluation using qualitative methods, was led from Cardiff, where we wanted to understand more about the intervention delivery and context and how it was being used. So these are quotes from participants in the trial where they describe the importance of accessibility. So co-locating the smoking cessation support on the lung screening van was really important for increasing access and overcoming things like practical barriers around transport, for example. Participants also really valued the availability of the trial team being there to support them and having a trusted relationship with the research team. So, for example, this person said they always had time for me. They made me feel important. They also talked about personalised and holistic delivery. So this idea of having a compassionate approach to building, to the researchers building relationships with participants to increase their motivation to stop smoking. And that's shown in this lovely quote, it's just people talking to people. So I think that shows the value of including diverse voices so that we can draw out these sort of subtle contextual influences around our trial design and delivery processes. And to show you some quantitative data from the trial, this flow diagram shows uptake of smoking cessation support within the wider Yorkshire Lung Screening Trial. And here you can see that 89% of those who were eligible for referral to see the smoking cessation practitioner agreed to see the practitioner on the mobile van, and of those, 84% agreed to ongoing support. So we think that, providing that accessibility and that person-centred care and support actually translated into really high recruitment and retention in a population that is typically underserved based on their levels of deprivation and their smoking history. So I'm going to finish with some recommendations for how we can include diverse voices in cancer early detection research. So first of all, we can think about diversifying our research methods beyond clinical trials. So we can use behavioural science frameworks to get these really important insights into the barriers and the facilitators among underrepresented populations. And we can use co-design methods with diverse stakeholders, including our PPI partners. And we can use qualitative methods to get a much more nuanced understanding of whether our intervention or our approach is acceptable and feasible to those populations. Secondly, we can think about decentralising our trials and studies to remove the burden of access away from participants and put the onus on the research team through, for example, using community outreach methods, building trusted relationships, not only with participants, but with the community organisations who are gatekeepers to access, so that we can boost and diversify the size of our study populations. And thirdly, we can think about addressing gaps in routine data, which I alluded to at the beginning of the talk, so that we can understand where the sources of inequality lie, and then think about how we develop and test some targeted solutions. So I'll just finish up by saying thank you very much for listening. I hope that's given you some ideas.